Good afternoon. My name is Dr. Milind Wagh, and this is going to be a short commentary related to the presentation on breast reduction that I've made earlier. I'll try to keep it short, but I want to summarize the issues that I've mentioned in my webinar. As we all know, breast reduction is really more of a functional procedure than an aesthetic procedure, because the women with massive breasts are miserable because of their various physical issues, the neck pains, the back pain, the chafing from the bra strap, the intertrigo, etc., which we've already mentioned in the presentation. As aesthetic surgeons, it's our job to give our patients the aesthetic shaping and the contouring along with the size reduction that they demand. Now, there are three basic issues as far as the patient is concerned which need to be explained to the patient. Obviously, the first one is scars, the second is the lactational potential, and the third is the nipple areola sensations, including the erogenous sensations that the patient can expect after a breast reduction surgery. Surgically speaking, there are three essential parts that we must address as surgeons as regards breast reduction. One is choosing the pedicle that will be transposed along with the nipple areola complex. The second is a parenchymal resection pattern which is used to reduce the breast tissue. And three is the skin resection pattern. It is very important to be clear that there can be various permutations and combinations of this which are not mutually exclusive, and they have to be used as best suits every individual patient. The most important issue as far as the pedicle is concerned is the safe preservation of the blood supply to the nipple areola complex, which is the most critical issue. And of course, the other is how much you can debulk it safely. With regard to the parenchymal resection, all resection patterns basically maintain the medial fullness, remove the lateral excess which is undesirable, and as far as possible try to keep the upper slope in the upper pole of the breast. And depending then on the pedicle that is used, either inferior or superior, you decide on how much you want to remove from the inferior half of the breast. I want to emphasize over and over that it is really what is left behind that is important rather than what is resected. So, to give the final shape, size and the contour, what is left behind based on whatever markings you have done and whatever tissue you have removed will finally give you the shape, contour and size that you want. One more important thing, the skin really is just the envelope. You simply cannot depend on the skin to provide you with a durable support. Depending upon the excess skin in which axis it exists, the vertical axis or the horizontal axis, you need to decide whether you can just excise longitudinally or whether you need to excise both longitudinally as well as horizontally. And based on this then is the final scar. It's either a vertical scar purely, or it could be what is called an inverted T scar, where there is both a vertical component as well as a horizontal component. There are multiple techniques described. We can all talk about those techniques at different times, and we can learn about them from books. But of all of them, really it is just two techniques that really need to be learned and mastered in practice. One, of course, is the superior or superior-medial pedicle technique, and the second, arguably, is the inferior pedicle technique. The advantage of the superior-medial pedicle technique is basically just a vertical scar. Because the medial and the lateral pillars are brought together and approximated, this tissue now provides support to the inferior pole of the breast, prevents bottoming out, gives it good projection, and also narrows the base of the breast, giving you all the criteria that actually are necessary in a good breast reduction surgery. On the other hand, any technique that adds a horizontal scar, we will always find that besides the vertical scar, whenever you add an horizontal scar, it reduces the projection, it flattens the breast, and promotes a sort of tethering of the inferior pole of the breast. And therefore, you will find that a lot of these breasts tend to bottom out. It is my personal belief over 15 years of experience that the vertical scar technique is really the gold standard. The argument against the vertical scar technique has been that sometimes there may be under resection, you have the problem of the dog ear, and sometimes you may have bottoming out as well. But there are modifications which I have explained in the presentation, with mathematical marking being done, precise mathematical marking being done, which makes sure that you can remove a huge bulk of tissue, you can reduce the largest breast, at the same time providing good projection, coning the breast nicely, lifting the inframammary fold, and therefore giving you a nice durable result. Two arguments as regards the inferior pole dog ear. It has often been said that you have to wait for the dog ear to settle itself, or you may require a secondary reshaping or a secondary excision of the dog ear. One, you can just imbricate the lower part of the breast only in the lower part of the vertical suture line, only in the last few centimeters, about 5 or 6 centimeters, or at the 10 centimeter mark from the vertical suture line, you can just add a short horizontal scar. If you do this, then all the arguments against the vertical scar technique practically disappear, and really it becomes the gold standard. So in summary, I feel that one must choose a technique which is user friendly, which is easy to learn, which has very good reproducibility in average surgeon's hands, and lastly, it gives you a good reduction in size as well as an aesthetic shape and contour. Thank you.